I'm Dr. Michael Atola, and I'd like to welcome you to this clinical presentation from Glidewell Laboratories. Today we're going to be discussing how to simplify combination fixed and partial casework. I guess a good place to start would be to define what we mean by a combination case. We use combination to refer to any time we have a combination of fixed crown and bridges and removable partial dentures in the same arch. And we're not just talking about the presence of both these types of restorations, we're talking about the complementary nature of these types of restorations. In other words, how can we use our fixed crown and bridge work to enhance our removable partials comfort, aesthetics, and retention? The reason we decided to make this presentation is because the topic of combination casework is taught poorly, if at all, in most dental schools. In fact, in most dental schools, the removable department and the fixed department are totally separate and rarely interact. As a result, most dentists tend to compartmentalize these procedures for most of their careers, often using two different laboratories to accomplish these procedures. I had a chance recently to attend the California Dental Association meeting here in Anaheim. There wasn't a single lecture on combination casework. Our goal today is to walk you through some cases and show you how fixed crown and bridge work can be used to improve the quality of your removable partial dentures. One of the most common mistakes made by dentists in combination casework is trying to cut corners by having the laboratory fabricate the fixed crown and bridges and the partials at the same time. Anytime you ask the laboratory to do this, they have to do a lot of guesswork, and there's always a compromise in quality and fit. You stand a much better chance of delivering restorations that meet or exceed yours and your patient's expectations if you follow all the right steps.
In my opinion, one of the most valuable services in dentistry is Glidewell Laboratories Combination Design Service. By sending in your preliminary models, our team of highly trained specialists will present you with a variety of fixed and removable options to meet your and your patient's needs. The clasps, rests, and framework design will be drawn directly onto the working models. Suggested clinically prepared rests will be indicated on the model, ensuring that you place the rest preps in the ideal location. Digital images of several different views of the working models can be emailed to you to enable you to provide treatment more expediently, rather than having to wait for the models to be sent back to your office. By following the suggestions of our design team, you can ensure that you will have a successful outcome for you and your patient. We have two design specialists with over 110 combined years of technical experience on our combination case design team. We are confident we have the proficiency to effectively evaluate and design even the most difficult combination cases. The average doctor does approximately 12 combination cases per year. Here at Glidewell Laboratories, we see roughly 800 combination cases in an average week. As a result, we have the most comprehensive knowledge base that would take most practitioners their entire career to accumulate. When we fabricate the crowns for your combination cases, it is done within our combo department. This ensures that the contours of the crown are ideal for guide plane and clasping considerations. Many doctors have their crowns made at their regular PFM lab, only to find that when they send their impressions to the combination or removable lab that the contours are less than ideal or sometimes even unusable. By having the ceramists in our combination department make the crowns themselves, the proper anatomy, rest preps, guide planes, and contours are built into every PFM. The first step in a combination case is to prepare and impress the teeth that shall receive the crown and bridge work. At the next appointment, try in the crown and bridge work and evaluate fit, aesthetics, and function, but do not cement the crown and bridge work into place. Instead, send it back to the laboratory in a pickup impression for the partial denture with the restorations in place. Resist the temptation to cement the restorations at this appointment. If the lab is able to construct the partial framework in close proximity to the restorations, there will be a much more intimate fit. Of course, this requires you to re-cement the temporary restorations at this appointment. The following appointment would be the try-in of the crowns, bridges, and partial framework at the same time. If everything fits as it should, you would then cement the restorations, take a bite registration on the partial framework, and send it back to the laboratory for processing. The bottom line is that if you learned only 3 things from this video that would improve the quality of your combination cases, it would probably have to be taking accurate pickup impressions. The second tip would be to not cement the crowns and bridges at the pickup impression appointment and send them back to the lab. Resist the urge to get the crown and bridge in place and just put the temporaries back on at this appointment. The last one would be to help you take accurate bite registrations. Anywhere you have an edentulous space, please make sure you use a wax bite rim to get the bite in this area rather than just squirting bite registration onto an edentulous ridge, which is what we call a mush bite. And you'll see some examples of that later in this presentation.
While they may not be the most exciting part of dentistry, and you probably won't see them on the cover of any of the journals anytime soon, partial dentures continue to be an important part of what we can provide our patients in dentistry. One of the reasons is the average 65-year-old patient alive today has 20 teeth left, and that's up a lot from the turn of the century. Traditionally, dentists who are working with patients 65 and over were dealing with edentulous patients, and today's 65-year-old has many teeth left for us to work with. There's 4 main reasons why we would want to consider partial dentures for a patient. The first one happens to be for economics. The patient who can't afford the large crown and bridge case or the implant case, for them, partials are a fantastic way to be able to give them an economical restorative option. The second reason would be for teeth that are periodontally involved, where the teeth are not strong enough to be abutments for a large crown and bridge case. The third one would be if we have a compromise in the overall health of the patient, if we don't feel their health is good enough for them to withstand the implant surgery and the subsequent surgeries. And the fourth one would be to use a partial denture as an interim therapy where a patient is perhaps saving money for a large crown and bridge case or for an implant case, but is missing their anterior teeth. A partial denture can be a fantastic way for them to have those anterior teeth in the meantime.
As with all of my removable and combination cases, I've sent the study models off to the design team to get their input on what they think will work best in this particular case. The way I look at it is I've been practicing dentistry for 17 years, and they've got about 85 years of combined experience between them on the design team for partials and combination work. So I'm going to let them help me out, and I think 3 or 4 brains is definitely better than my 1 brain. In fact, I know that for a fact. So let's take a look at the design they come up with for this case. Again, we don't want to show a lot of metal whenever possible. The typical partial that just has the eye bars on it are types of partials that I've seen a lot of patients not wear because they hate to smile and have that metal showing, if at all possible. So what we have here is a single crown on tooth number 6 with a laboratory prepared rest. So again, I don't need to prep that rest, but I am going to go ahead and prepare that crown and then prep a rest into that. It's not totally necessary that it's going to be there, unlike a clinically prepared rest on a tooth, but I want to make sure they have enough room. They've suggested a VKS attachment here, which I'm very happy with. I like VKS attachments a lot. They want me to splint the crowns together on teeth number 7 and 8, and then they would like a 3-unit bridge on teeth number 9, 10, and 11, splinted together a VKS attachment off the distal of number 11, and again a laboratory prepared rest here. So this is a pretty straightforward crown and bridge case for me at this point. I just need to go in and prepare these 5 anterior teeth and do the kind of thing we do all along. Could you splint all of these if you wanted to? Yes, you could if you think it's necessary for retention or the teeth happen to be periodontally involved. These teeth are pretty strong, and I would rather give the patient the opportunity to floss in as many areas as possible without using a floss threader. So I'm not going to splint these 2 centrals together, even though you could kind of make an argument for splitting these together so they never moved apart. But looking at it from a periodontal basis, this is a patient who I know wants to take care of his teeth, and I'm going to give him the opportunity to take care of it in as convenient a fashion as possible by leaving it unsplinted where they can be unsplinted. Again, a couple of different views here so I can see what kind of vertical height we have here in terms of the space we need for the VKS attachments. See it from a couple different views and get an idea what's going on. Anytime we see something colored in yellow, that tells us the laboratory will be fabricating a restoration for those teeth, and those are the splinted crowns, the single crown and then the 3-unit bridge up in the anterior. On the lower, as we look at this looks relatively straightforward. We've got a couple clinically prepared rests here and here. So this is one on the occlusal that is prepared, and then we have one on the lingual cingulum that's prepared, and then over here we have a transocclusal rest. It's going to be on both of these bicuspids here, and the partial is going to come up and sit down on that area. We have a little snubber clasp over here, which refers to something that usually does not cross around the height of contour. So we have a clasp here that won't be visible from the front, an Akers clasp here on the lingual of the second bicuspid, a modified roach, and Akers on the lingual here.
Another roach on the first bicuspid on the other side as well. So pretty straightforward partial, but for me it's really helpful to know where to put the rest preparations. For example, I like knowing to place the occlusal rest here on the bicuspid and the lingual rest here. I would not have known necessarily to place that there. I would have not necessarily have known whether or not they needed one on the cuspid over here. They do not need one because of the two rests that we have over here on the bicuspid. So by allowing the design team to design this clasp for me, they were able to let me be able to do something that was more aesthetic. And you can see on this modified roach clasp how the metal's going to come off of the mesh in this area, and then it's going to move gingivally, and the metal's going to come over and the clasp will engage the gingival third of the bicuspid on this side and then over on this side as well. So by allowing them to design the ideal partial for me, knowing that the patient didn't want to show a lot of metal, we now have this clasp where most of the metal is going to be hidden under the lip, under the smile line in the buccal vestibule, and then just a little metal is going to be visible at the cervical third of both of these bicuspids. And it's very rare that a patient smiles and will be able to see the cervical third of the first bicuspids. So again, the patient and I will be happy to have little or no metal showing here. As we look at the technical notes for this case, again, these bring up a lot of things. It explains a lot of decisions made by the design team as well. For example, it says a broad posterior palatal strap design will be utilized to demonstrate the preferred maxillary free end support feature despite the presence of exostoses along the median suture. Should the patient not tolerate the presence of the posterior palatal strap, we will remake the partial with a horseshoe major connector design. So again, the original design calls for this broad posterior strap because of the bilateral free end nature of this denture, and they have already explained to me that if the patient can't tolerate that because of any tori that he has in the midline, they'll remake it as a horseshoe design, but that this is the preferred design for this partial. So not only do you get a great design for the case, you also learn about why certain decisions were made for this particular case, and at the same time it helps educate you for cases in the future about why these types of things are done. So I love those technical notes. I always feel like I should receive CE just for going through this design service because I always learn about the partials as we do this. And again, we've got an estimate of cost that is good for a month from the time it's received. That takes into account the PFMs that are going to be done, porcelain fused to semi-precious alloy. I love using semi-precious alloy. Bridge connector joints, rest preps, epoxy models, fixed attachment and labor. These are all things that probably slip your mind if you're adding up in your mind how much these partials are going to cost. And again, we have a grand total here of $1,608, which allows me to work backwards and figure out what we're going to charge. Some dentists figure it on an hourly rate. Some dentists will just take this number and multiply it by 5 or 6, like they would for a crown and bridge fee to come up with their final fee. But either way, when you get into more complicated designs like this, I don't recommend you just charge your standard partial fee and go from there, because to make partials like this that are going to have nice attachments that help retain these, that are going to show a minimum amount of metal, it's going to be more expensive, and you really do need to adjust your fees. In fact, you may give the patient the option of having this fee, base your fee based on this lab charge, to have a very aesthetic partial with some nice attachments, and then maybe give them another one for a bare bones partial with just standard clasps and none of this extra stuff based on your regular partial denture fee. But at least this way there will be no surprises for you when you get the lab bill, and it will allow you to charge what you need to charge to be fairly compensated for a case like this.
This case is an interesting one because the patient came in to have some crown and bridge work done to improve his appearance on his upper front teeth. And you'll notice tooth number 10 is broken off of the gum line. That had to be removed. And he wanted a bridge from tooth number 9 to 11 and then crowns on 6, 7, and 8 just to improve his smile and make it look a little bit better. And as I examined his mouth, I realized that all of his upper posterior teeth were gone. And as we looked at the lower arch, his lower molars and one of his lower bicuspids were gone as well. So I suggested he may want to consider doing some partial dentures to replace all of these missing teeth. But at the time, he decided just to go forward with the crown and bridge on those front teeth. And after we prepared him and impressed and temporized him, he stopped by the office to tell us that he had thought about it. And he did, in fact, want to replace all of those missing teeth. So we called the laboratory and let them know that this was now going to be a combination case. And the case was sent from the PFM department over to the combination department. The combination department here at Glidewell has their own PFM team because they want to make sure that the PFMs have the exact contours and guide planes and really have all the characteristics that are necessary to help retain a partial denture. So when the patient came back into the office and we removed his biotemps, I'm removing the biotemps here, we had already let the laboratory know that this was going to change from a regular crown and bridge case to a fixed combination case where we were going to have some fixed bridge work and some partials as well. And the two of those entities were going to rely on each other for support, strength, and function. So at this point, they've already been fabricated, and so we are going to try in the bridge from 9 to 11, the splinted crowns between number 7 and number 8, and the single crown on tooth number 6. You can see we have an ovate ponic receptor site on tooth number 10, and that tooth was extracted and the biotemps were placed immediately into that socket to help kind of preserve that spot. And as I try this in and push down on it, you can see we've got some tissue rebound, and as I push up on it, the tissue blanches slightly. And I've intentionally prepared this bridge that way. With the two-chord technique, I was able to prepare slightly subgingival margins without ever having to take a burr under the gum tissue and risk tearing it up or doing any damage to it. And so when we put these restorations into place and we have to push on them, and here I'm pushing with an orange wood stick just to save my fingers a little bit, and I push them into place, it allows me to check the incisal plane, and it allows me to eliminate that tissue pushback when I want to see how far these are going to actually seat. When I put these bridges in with cement, of course, that tissue pressure will be negated and that blanching will go away in no more than, say, 20 or 30 minutes. But I want to have a nice tight fit. And here you can see between number 6 and number 11, the VKS attachments coming off the distal of both of those teeth. Very critical point here. We're about to do a pickup impression. We've tried the crowns in. We have now taken the crowns out and we are temporarily cementing them into the mouth. If I only wanted you to learn 5 things in this DVD presentation today, this would be one of them. Number 1, that you have to temporarily cement these restorations into place to ensure that you get a good pickup impression. One of the big problems we see in the laboratory is inadequate pickup impressions, and this usually happens because a dentist just sets these units into place and then takes an impression. And when that happens, the restorations always move on the teeth, and the laboratory ends up getting a pickup impression that is not accurate at all. So you can see my dental assistant has taken the polycarboxylate cement from Ultradent, mixed some Vaseline in it to keep it from setting rock hard, and we're now temporarily cementing these units into the mouth. Is this a little bit of a hassle? Well, it's a little bit of a hassle to clean up, but you know what? This is the only way to get accurate pickup impressions. I've tried other things. I've tried putting fit checker inside of these crowns. I'd even tried that on a couple of these cases for this DVD. I've tried putting extra light body impression material, and it just doesn't work. If you want to have these cases be predictable and go very easily for you without a bunch of appointments, you need to temporarily cement those units into place. Now my assistant has a perforated custom tray. She's painting adhesive on it, and we are using our impression material to go around the attachments here with the intraoral tip going around the VKS attachments to make sure we pick that up. Going around the gingival margins of the PFM as well. I just want to make sure we get all this detail for the technicians back in the laboratory. So we're going to go along the lingual margins as well. We're going to make sure we go all around the VKS attachments. That is a monophase material called Capture from Glidewell Direct. And you can see the same color monophase material in the tray itself. The monophase material is very thixotropic, and as a result, it won't push tissue out of the way when we're taking a full arch impression for a removable like this. You can see the temporary cement inside the crowns in the pickup impression. That's very important. The restorations stay inside of the pickup impression, and you can see the temporary cement. Do not cement these crowns into place right now. This is the second thing I want you to learn today. If you're only going to learn 5 things, the second thing to remember, do not cement these PFM restorations just because you have them in your hand today. I know it seems like a natural thing and it seems like something that's going to be in the patient's best interest instead of wearing temporaries, but if you don't send these PFMs back to the combination department to help them make the framework, once again you're throwing a wrench in the works, and the chance of it working out is going to go down significantly.
I had an opportunity recently to speak to some of our combination department technicians with some of their tips regarding impressions. First of all, triple trays should never be used for a combination case or a bridge. The second point, we would like a full arch impression along with the quadrant if the case is 4 units or more, and we won't be able to fabricate crowns with attachments on a quadrant impression as we need to establish a path of insertion and parallel cross arch.
We are now looking at our design sheet and seeing that we need to make some clinically prepared rests here. On the 2 lower bicuspids on the lower right, we need to make our rest preps. And on the lower left, we need to make a clinically prepared rest in the mesial pit of the bicuspid and one on the distal lingual of the cuspid. Now, I'm using a round burr here as I was taught in dental school. And the lab pointed out to me that when I used the round burr and they took a look at it, that they had a problem seeing the draw, the path of insertion here, and there was undercuts from the round burr. And it kind of makes sense. If you insert a round burr down to make a inlay type preparation into the tooth, which is what we're doing with a rest prep, if you go beyond the height contour of the round burr, you will in fact end up with an undercut. Undercuts are bad news. So here I am using the correct burr. After they called me and told me that this is an 845 KR 018 burr, basically a small inlay burr that you would use for a bicuspid inlay. And because of the taper that's built into this burr, it's going to make sure we don't undercut any of the walls, and with the modified shoulder on the internal line angle, it's going to make sure that is nice and smooth as well. And you can see the difference in what these rest preps look like. We want the rest preps to be deep enough where the rest that's going to go in there is going to be thick enough so the metal doesn't have any problems, and we want it to be deep enough as well so that it doesn't affect the occlusion. We don't want to have to adjust the opposing teeth just because we have an occlusal rest there. So once they taught me how to make these the right way with the correct burr, with the inlay burr rather than the round burr, we did that, and we are now taking our final impression after the rest preparations have been done. Again, using the monophase material. The monophase material being so thixotropic, it'll pick up lots of small details in the rest preps and the teeth around there and things like that. And then when we actually place the monophase material in the custom tray and put that into place, it won't push tissue around and give us a false impression of what the soft tissue or the residual ridge looks like. And that's why we like the monophase material, as opposed to using, say, a heavy body polyvinyl siloxane material or a putty material or something like that, which will push soft tissue out of the way. You can see as we look at this impression at the residual ridges on both sides that it looks nice, and you can see what a good job it does, not only recording the teeth in the anterior and the rest preps, but recording the soft tissue anatomic landmarks such as the residual ridge as well. It really does a nice job of doing that, and so monophase is the material of choice for those types of impressions, including pickup impressions. Then we're going to go ahead and take the temporaries off. We now have the crowns back at the next appointment, and the framework has been made as well. And you can see that I've engaged the bridge on the one side and the single cuspid on the other onto those VKS attachments as I try it in. And you can try those crowns in first and make sure they fit. Again, I've already had them in once for the pickup impression. They fit fine, so I know they fit. Now what I'm trying to do is check the relation of all this stuff to each other to make sure that it all fits. And so I like to put the crowns in the attachments first, because for me it's easier than putting the crowns in and trying to push the partial down and push it down and engage those VKS attachments into the female. So we just try it in like that to see how it's going to look. Let's take a closer look now at this upper partial denture. It's a very aesthetic upper partial denture as you look at it. You'll notice there's no clasps anywhere. We have our major connector there. It's really about the only metal you see, with the exception of the mesh there. And you can see the two female VKS attachments, which are just to the distal of those two cuspids. One of the things you need to remember when looking at study models is how much vertical space we need for the VKS attachments, or the trailer hitches, as my patient called it. And you need at least 5 millimeters, preferably 6 millimeters, between opposing arches to have room for an attachment like a VKS attachment. On the lower, there was no need to do any crowns on those teeth, and so as a result, we went with a more conventional partial and did not use any attachments of any kind. Of course, on the lower, because of the way patients smile, lips tend to cover these up. We've got an Akers clasp on one side. We've got a Roach clasp on the other side. And it's not as big of a deal on the lower when the patients smile, because you really don't see it. You tend to see the incisal half of their lower front teeth, but not too much more of the partial beyond that. So Given the choice between making an aesthetic partial on the upper or the lower, most patients will in fact choose to make it on the upper and have the conventional one be on the lower arch. Okay, now that we're getting ready to cement the units, we're cleaning up the teeth with some Concepsis from Ultradent. Obviously you got to assume that your temporaries maybe have leaked a little bit, or at least saliva has gotten on these teeth today since we had the temporaries off. So we're cleaning up everything with this disinfectant, and then we will go ahead and rinse it off in preparation to cement these units. So now that we have disinfected the preparations, it's just a matter of keeping them somewhat dry. Unlike in the old days where we really had to air dry the preparations and get them bone dry, today we're just looking to avoid pools of moisture. So I'm just using a cotton roll here to make sure that everything is nice and dry. The resin reinforced glass ionomer cements like this one don't require they be bone dry. And you'll notice I've got the bridge on the one side and the crown on the other side already engaged in the VKS attachments. I've had difficulty over the years when we seat the crowns and try to engage the partial denture into those. It makes it difficult. So we put them in all at the same time here. And what I want to do is ensure that I've got the attachment engaged when it goes in, so I don't have to worry about maybe not being able to get that to engage. And now I've got cemented PFMs and I can't get it to engage, and I've got to redo my attachment. So when I insert it, you could tell it was kind of a hassle when I did it, because it's actually difficult with the crowns in place kind of hanging off of there to insert this whole big unit with the partial on it. But whether it's just a regular clasp on the partial around the crown, or whether it's an attachment like this VKS attachment, you will always see me put the partial and the restorations in at the same time to ensure that I have the proper relationship between the two. The partial's still in at this point as we're cleaning up the excess cement. This is Reliax Luting Cement Plus from 3MSB. Very easy cleanup, and we're cleaning all the facial areas, everything that we can get to, even though the partial is still in place. And we're going to make sure that the cement has plenty of time to cure on the 3-unit bridge from tooth number 9 to 11, and on the single unit PFM for tooth number 6. And once that has had enough time to set and we're not worried about those coming off anymore, then we will pop out that upper partial, which disengages those two attachments, and then we'll go ahead and clean around the lingual and interproximally remove any excess cement that happens to be there, put the partial back in. We then delivered the conventional lower partial that just required the clinical rest preps and didn't require any restorations. And now we're just checking the occlusion to see how everything looks. Make sure that our lower rest preps aren't interfering with anything. As I take out the lower partial, I can see one spot that appears to be high, and then I have the patient bite together without the lower partial in, confirming that there is, in fact, a spot on the lower partial holding open the bite. And I adjust that out of the mouth, put it back in. And you can see here in the portraits how nice he looks afterwards. Before, when he smiled, he had space between those front teeth and had that missing one on tooth number 10. And when he smiles now, and we're probably going to have to retrain him how to smile a little bit, you can see the fact that he's got a nice broad arch and a color that he picked, a shade that he picked that looks really nice in his mouth. And he's never regretted, since we've delivered this, go ahead and replacing all those posterior teeth as well, even though he was more interested in the beginning in this case, just from the aesthetic standpoint. We were able to replace a lot of lost function for him and have him still be happy aesthetically. This impression is an example of a failed pickup impression. It's pretty obvious when you look at it that it is in fact a failed pickup impression. If I turn the model over and we take a look, you can see the large amount of space between the framework and the palate itself. You can also see, if we look from this angle again, that the partial is sitting many millimeters back from the teeth themselves. And the reason this happened is because of this broken clasp over on this side, and the fact that the partial was being sent in to have two teeth added that were acting to clasp the partial denture. So it's not surprising that a partial like this would shift during a pickup impression, but still something needs to be done about it. And one of my favorite ways to accomplish a pickup impression on a non-retentive partial denture like this is to put it in all the way, use a little denture adhesive under any saddle areas you have like this one, and push it down all the way. And then I'll use some flowable light cured composite right along the margin between the teeth, and I'll work it into the embrasure and run it onto the metal just to kind of spot weld the partial into place.
Again, we're going to use a lighter body impression material when we take this impression, because if we try to take this with a putty or a heavy body material, we're going to stand more of a chance of pushing that partial around and pushing it out of place. So we need some way to temporarily put it down into place, whether you want to use acrylic or a bisacryl temporary material or a light cure composite. It really doesn't matter as long as you can just temporarily fixate that partial into place before taking the pickup impression. Another common problem that makes it very difficult for the technicians in the laboratory during a combination case is when crowns that have attachments on it, like the ones you see here, are cemented into place on the teeth, and then the impression is taken for the partial denture. For example, these 4 crowns that are splinted together, you can see the attachments coming off the distal of both of these crowns, and now the laboratory has had to try to place an analog here that they can use to construct the partial denture. This is going to make life really difficult for the technicians, and that's not the important part. The important part is that the chances of this fitting in the mouth are pretty much slim and none. And really the best way to do this, and one of the more important things you'll learn from this presentation, is that when you have crowns like this with attachments, do a pickup impression. You know, take the temporaries off, clean up the teeth, try in the crowns, verify the fit of the margins and everything else. Take a pickup impression and then send these crowns back to the laboratory in the impression and let the lab pour it up. When the lab has the actual crowns and the attachments and can build the partial framework, that way you stand a much better chance of having something that's going to fit very nicely and something the patient will be happy with. Let's take a look at the impression for this case. On the impression, you can see the crowns are well represented and you can see the attachment as well, but it's very difficult when you pull the impression out and the attachment stays in the mouth to be able to fabricate a proper framework for this patient. If you look at the impression itself, obviously for a partial denture, we'd like to have more information back here. There's a huge void on the palate in this area. And just in general, as we look at this, it was taken in a stock plastic tray. And the chances of this fitting the patient's mouth accurately really, again, are slim and none. So again, this is a case when we're going to this much work and you're putting in this much work to do 4 splinted crowns with 2 attachments and a partial, this is the kind of case that absolutely screams out for a custom tray. With a custom tray, you can be assured that you're going to get all the landmarks, all the periphery, all the borders, including this one, that you're going to need to get if, in fact, you put enough impression material into the impression. So a couple things wrong with this impression, but namely it was taken in a stock plastic tray rather than a custom tray. In this case, I like the dentist's idea of using a custom tray. Certainly we would encourage you to do that for any kind of partial impression or combination case. But as we turn it over and look, we've only got 1 viscosity of material here. We have a void in the back, and we can see that we do not have an impression of the palate here, and that's just simply unacceptable. We must be able to see everything from the teeth to the periphery, and when you look, we don't have a lot of anterior periphery here. This is a case where some border molding would have come in handy, and if you think the impression looks bad, when you get a chance to finally see it on the model, you can see that there's really no room for us to see in the vestibule where that flange needs to go. And then obviously in the palate, we just have a total lack of information here, which makes it a completely unusable impression. You know, I'd like you by the end of this presentation to be able to recognize that if you do not in fact have all the palatal detail in the impression, that you should go ahead and remove the impression material and just go ahead and take it again. And border molding never hurts in any area we're going to need a saddle. Any edentulous area, certainly border molding will come in handy unless the custom tray happens to extend into those areas well. This doctor in one case has managed to send us both types of impressions that we don't like to receive here at the laboratory. The first one is where you take an alginate impression in a stock metal tray and then you pour it up in your office and ship it to us just like that. And obviously by the time it gets here, the alginate has dried out and gotten very stiff. And when it comes time for our technicians to remove this tray, it's very likely that we're going to break some teeth. And we attempt to rehydrate it and soak it in water overnight to try to get the life back in the alginate, but it just doesn't happen. And this is a difficult way for us to work and maintain an accurate impression, especially because since the alginate is totally distorted, we don't get another pour on this type of impression. So really we get one chance to try to make it right, and it's a difficult situation to work with. So we prefer not to receive impressions like this. And then on the upper of that same case, the doctor poured the alginate in his office, and then when he removed the alginate the next day, snapped off these 2 anterior teeth and sent them along with the case. And so now these are 2 teeth that were prepared, and we're having to try to cement these back onto here, and that's another difficult situation. Really the best way to do this and to avoid both of these problems is to use something like a polyvinyl siloxane or a polyether impression material and just send it to us and let us pour it up, and we have multiple pours if we happen to break something, and it's just the safest way for us to be able to have that impression during the entire fabrication procedure, just in case we need to pour another impression. We like the accuracy and the stability of both the polyvinyl siloxane and the polyether materials as opposed to alginate. And I realize alginate is cheaper, but we're trying to make something that you're going to be happy with and the patient's going to be happy with. So we'd rather not have you use alginate and pour it up in your office or send it to us unpoured and have you use one of the most stable impression materials instead. Also on the same case, the doctor chose to use this wax horseshoe rim to take the bite. And these wax rims are notoriously inaccurate. They're temperature sensitive. This doctor happened to be shipping the case to us from about 2,000 miles away, and during transit there's an opportunity for these wax bites to get bent as well. And when you look at the case, there's enough edentulous areas here between this one, this one, this one, and this one, where we would really be better off making a wax rim, making a bite plate with some wax on it that you could put into the patient's mouth. The patient's got a very deep palate. It would seat very nicely into that. And we would make sure we got a nice, accurate bite registration. To simply take some horseshoe wax like this and soften it up, put it in the patient's mouth, have them bite into it, and expect to get a very accurate bite registration is just a stretch. And if you have something made, a bite plate with a wax rim, and use that to take this bite, we can almost guarantee you good occlusal results. This case represents another bad bite registration. In fact, when I turn the articulator over and take a peek at it, I can tell something is wrong here just by looking at the overjet and the overbite between these anterior teeth. And what the doctor actually sent into us was a full mouth wax bite, and this went all the way around the arch. And it went over to the opposing side as well, so that when we attempted to close the model down into the bite, we had no contact between these teeth. And that's simply not how a bite like this is supposed to be. What we'd like to have in a case like this is a registration between the prepared teeth and between the opposing teeth. We'd like a harder material than a wax bite for something like this, or what's traditionally called a mush bite. And we'd like to have it be one of the high durometer polyvinyl siloxane materials like Capture Hard Bite or Blue Moose, something like that that's more stiff. And really all it needs to represent is the incisal 1/3 of the preparations and the incisal 1/3 of the opposing teeth. And then the teeth on the contralateral side should be in contact so that we can see that the patient is in fact in their correct bite. To take a wax bite across this entire arch and have the patient bite into it is going to be a very inaccurate way, and we can tell just by looking at this bite that it is in fact inaccurate and will need to be taken again. This is a case from a doctor who wants to prepare these 4 teeth for crowns and put precision attachments on these 3 teeth and build a partial denture. The only problem, and why it's been held here at the laboratory, is that he hasn't addressed the vertical dimension before beginning this procedure. And when the patient closes down into their bite, you can see the lack of space that we have here. And one of the rules of thumb that I'd like you to come away from this presentation remembering is that we always need 5 millimeters of space between where an attachment is going to go and the opposing tooth. I have a calibrated measuring device here that measures 3, 4, and 5 millimeters respectively. And we're going to go ahead and place this between the ridge and the opposing tooth to see how much space we have. And I actually can't even get the 4 millimeter measurement to go in between the ridge and the opposing tooth. And if we take a look over here on the mesial of the cuspid, again it's the same thing. The 3 millimeter barely wants to go in. And if we look back at the molar, we have no problem. We actually have 6 millimeters of space over there, so an attachment there would be fine. In your office with some study models, you could certainly measure it yourself with a periodontal probe to see if in fact you have enough room there. Probably the better idea is to send it in as a design case to our design team and let them take a look at it and measure it and see whether or not this would be a good case to open the vertical dimension if in fact you want to use some attachments. This partial framework was returned to us from a dentist who had to go in and do several modifications to get it to fit, cutting away rest prebs, totally eliminating guide planes, and it was just obvious from the start that this framework was not going to fit and we are going to have to remake it. So what we do in a case like this is go back to the impression and see if we can learn anything about what might have happened. First and foremost, again, for a partial denture, a custom tray just can't be beat. And here we're looking at a stock plastic tray that is never going to fit the patient's mouth. It's not meant to be accurate in edentulous areas like the saddle area on that partial denture, and so it's really made for crown and bridge, and to use it for removable or combination purposes like this is kind of an abuse of that tray. And when you look at it, you can tell this is a putty that's been used because of the streaking. So the putty hasn't been mixed completely, but I really don't think that's the big problem. The problem is using a stiff putty like this in combination impressions like this, it's too stiff and it pushes tissue around and pushes tissue out of the way and distorts things, and we end up getting a model that's not as accurate as it could be. We would prefer that you take these types of impressions with light body or extra light body, really material that'll flow well around the teeth and around the tissue without distorting it and pushing it out of the way. So putty is fine for crown and bridge impressions where soft tissue issues never come up and it's all about the hard tissue. But when we're taking a combination or a removable impression like this, the putty just overpowers those thin, friable tissues. And as a result, we end up with a distorted model in a framework that doesn't fit. So again, light body and extra light body materials are the way to go for these types of cases. This is a case from a dentist who wants to do an upper partial denture, and on the lower, he wants to do a combination case with a couple of crowns and an attachment. And that should all work out fine, actually. The issue here has to do with the bite itself. And the bite for this large case was taken with some base plate wax. And base plate wax, like most other waxes, is historically inaccurate and just not a great way to do it. And we're able to place it on the model and kind of guess where the bite registration needs to go. But then again, if you squeeze it a little too hard, you'll put new indentations into the wax, and we get real leery of that as well. The better way to do this case and to get a more accurate result and a happier patient in the end is to make a bite block and have that fabricated for the upper arch and have wax placed into each of the edentulous areas. And when the patient bites down into that after you've had a chance to warm it up, it will record the registration between the prepared teeth and the wax across from it, as well as the edentulous area over on the other side. This is a lot more accurate because the wax is a lot thicker, and because we have a base plate that's going to fit pretty darn well up against the patient's palate and remain stable in place, and we're able to articulate those without many questions. When we get a wafer like this with the case, we always feel like we're guessing, and it's easy to ruin this bite because it really is fairly reversible. It's able to be bent if you handle it a little too rough or due to temperature or even during shipping. So again, we prefer not to see wax. We prefer to see a bite plate with a wax rim on a case like this. On a case like this where we have several treatment options, perhaps the best way to treat it is to take some diagnostic models like we have here, and we send them into the Glidewell combination department so they can go ahead and do a design survey on these models. And we get this back, and we get it back in the form of models and in a written form as well, which makes it easier for us to be able to figure out what we're doing. So let's take a look. These are the original models. I'll just move these up a little bit. And then the design models come back from the combination department, and we'll take a little closer look at these models to see what has been suggested by the design department. Again, there are any number of options that could be available. We can choose from 3 or 4 different options to see which one best meets our needs, the patient's finances perhaps, and we have settled on a design here that accomplishes all of our goals and does it without really inflating the cost to a level where the patient might be uncomfortable. So let's go ahead and take a closer look at what's been designed for us by the design team. If you noticed on the preliminary model, we had a couple teeth in the anterior that needed to be extracted, tooth number 7 and tooth number 8, and those have been socketed here on the model. And you'll notice they're colored in yellow, as well as the 2 adjacent teeth. And anything that's in yellow that comes back from the design department is going to be fixed prosthodontics. In this case, it's going to be a 4-unit bridge. So at today's prep appointment, we will be preparing the 2 abutment teeth and then placing a 4-unit Biotemps bridge into that area. As we look at the lingual of the model, we can see a few other things. Any of the red circles that you see are clinically prepared rest preps. So here the laboratory is telling us they would like us to make a rest prep on the mesial of the molar here, the distal of the bicuspid here. They would like to see a rest prep on the lingual of the lateral incisor here, and then 2 adjacent rest preps on the bicuspid. You'll notice there's also a rest prep that's on this yellow tooth, which is the abutment for this 4-unit bridge. And so basically what they're telling us is that this is going to be a laboratory prepared rest. So really all we need to do when we prepare this tooth for the PFM bridge is to make sure we keep in mind they will be placing a rest in the lingual, and we'll go ahead and place a rest preparation into our crown prep to give them enough room to build that into the lingual surface of that PFM bridge and still have proper contours in this area. You can also see the major and minor connectors drawn out for us, as well as the clasp design that's here. But really the important thing for us when we look at a model like this is to figure out during the preparation appointment exactly where and what size the laboratory wants us to place rest preps. And it makes it very easy when they've marked it directly on the model. I'll often set this right on the bracket table, or sometimes even the patient's chest, and just go right along and make sure that I've done all the preparations that need to be done. On the lower model, a little more straightforward. We've got the patient's going to have a couple wisdom teeth extracted back here, and we're going to have a bilateral distal extension lower partial denture. And again, the lower is going to be relatively straightforward with just a couple rest preps prepared here, and then some clasping on the outside as well. Let's go ahead and take a look at the paperwork we received back from the design team. This is the paperwork that comes back from the design team with the case. And actually one of the nice aspects of this is that it gets emailed to you as well if you have access to an email account. So it's a relatively quick turnaround. We can send a case into the design team. They'll go ahead and design it for us and email this back to us the same day. And rather than having to have models go back and forth, I can go ahead and approve their design and email back to them that that's okay, and any custom trays or bite blocks that need to be made can be started at that time. So as we look around, we'll notice some of the clinically prepared rests that I mentioned before on the model. So really what this does is explain to us everything that we saw on the model. And in case you have any questions about what's there, they'll show you what they plan on doing in terms of the clasping. Here's a back action clasp around in this area. They'll show you where the mesh is going to be. There's an Acres clasp over here, a modified Roach clasp. And if you have questions about any of the clasps that the design team has picked out for you, you can certainly call or email them and ask them about them. So this is before the models actually come back. We have an occlusal view, a facial view, and then the two lateral views as well. So you really get a good idea, a virtual idea of what the model is going to look like when it comes back. And this will cut a couple days off the patient's treatment time because you're able to approve this without having the actual models in your hand. And again, for the lower, you can see a couple clinically prepared rests here, and then where the mesh is going to go back for the metal framework, and then those same views of the lower model as well. So you can approve this via email, and again, not have to wait a couple days for the models to be returned to your office and then for you to send approval back to the laboratory. So it really streamlines the whole design process. As we look at the radiographs for this patient, we can see a couple of the broken down teeth in the anterior that need to come out, little endodontic involvement here. Endodontic involvement on the tooth next to it too, and a lot of decay. By the time we cleaned it out, we would have been down encroaching onto the level of the interproximal bone, so a decision was made to remove those two teeth. And on the lower, we have a couple bombed out wisdom teeth in the posterior that are going to be removed prior to fabrication of that lower partial denture. Bony support for the rest of the teeth that are being considered as clasp teeth for the partial dentures look pretty good. As we look around at the other teeth, the teeth that will receive clasps or the teeth that will have the PFM bridge on it, the bony support really does look good, so we don't have any compromising factors on those teeth. There are no teeth that cannot handle being clasped in this case. A copy of these x-rays was sent along to the design team in the laboratory so they could look at the x-rays as well and see whether or not the teeth that they would want to clasp could in fact support the clasps. And as they had a chance to look through the x-rays and take a look at these different teeth, it was apparent to them that we did in fact have enough bony support for those teeth to be able to bear the weight of a clasp. And it's nice to be able to either email or send a copy of the x-rays along to the design team. They're used to seeing them, and this certainly helps their design making decisions. One of our many chairside guides available to you from the laboratory is this one on simply natural partials. You'll notice it'll show you the differences in teeth. It's got some before and after pictures you can share with your patient. It shows you some common clasp and aesthetic clasp designs and some framework options that you have. And then on the back it'll show you some detail about how to take impressions, what we're looking for in an impression, and then I'd like to draw your attention over to the rest preparations. And you can see that it shows what a common occlusal rest is supposed to look like. You can really use any burr you want. My favorite burr for doing this is an 845 KR 018. Diamond burr, and it's an inlay burr really, and if you look at this, this really does look like an inlay, a very, very small inlay. So I like to use an inlay burr. In dental school I was taught to use a round burr, but I just got a different shape, and I ended up having too many areas of my rest preparations that weren't deep enough, and it ended up compromising the patient's ability to occlude correctly, and if I had to make any adjustments on the metal, I would end up grinding right through the rest itself. So you can see what a channel rest would look like on a molar. An inverted V rest typically done on anterior teeth, especially on a cuspid, so that we have a nice hard tissue rest over the cingulum. And then some interproximal preparations that you can see, like we have on this patient on the lower, where we may need access from the buccal or the lingual. So we're going to prepare again our inlay preparations and then widen them out and open the proximal space so that the metal can come up from either the buccal, the lingual, or in this case just occlusal refs only with some metal coming in from the lingual. So again, you can call any of us here at the lab and request one of these chairside guides, and I think you'll find it to be very helpful for your partial denture cases.
On this case, the patient's aesthetic needs are obvious. We have a couple of teeth in the anterior that are decayed down to the gum line and going to need to be removed. We're going to place a 4-unit bridge from 6 to 9 on this patient, and then we have a tooth missing, number 11. We're going to replace that tooth with the partial denture, and tooth number 5 is also decayed down to the gum line, so we'll remove those root tips, and we're also going to place a replacement tooth there that's going to be on the partial. First step in any of these cases, we want to go ahead and take the shade before the teeth have dehydrated. You see we're using the Vita Easy shade here. This has become one of my favorite products. I've had an opportunity to test just about all of the digital shade taking systems, and I agree with the name Easy Shade because it is pretty easy. And we go to the teeth next to where the bridge is going to be, or the teeth themselves, and take the shade, and you can see the kind of reading that we're getting here. An A4, nice base shade. In the cervical third, it's a C4. So you can take shades in a couple different areas on the tooth, and then we will also take a digital photograph with that shade tab in place. So the C4 and the A4 shade tabs will be in place, and we will go ahead and send that digital picture with the tabs in place to the laboratory, along with a printout of what the Vita Easy Shade saw on the teeth themselves. Digital photographs are very helpful for us here in the laboratory, but they're really helpful when we have a shade tab in place, so the technicians can relate that shade to the tooth color itself. We're placing the topical anesthetic here. This is Profound from Stevens Pharmacy. This has been my everyday topical anesthetic for a long time now, over 2 years, and it is Profound. Its name is correct, and it's very, very strong, and most patients will feel nothing or almost nothing if you leave this in place for 60 seconds and then inject into the same area where that topical anesthetic was. I've even been able to do lots of laser soft tissue surgery without an injection, just using that. So we've anesthetized the patient now. Because it's an infiltration, we're using Septicane. You can see the 2 teeth have already been removed, and we're now preparing the teeth that will accept the bridge, and we're using the reverse preparation technique. So we're starting off with the round burr, the 801-021 burr in the cervical third. And again, we're doing this to create our margin. This is going to do 90% of our margin creation for us, and it also ensures that we have enough reduction in the gingival third so that when the combo department goes to fabricate our crowns, they're going to have enough room in the cervical third for the metal coping, the opaque, and the stacked ceramic as well, and we can still have a nice emergence profile. We use the same round burr on the lingual to create our margin there, and we're going to go ahead now, and we're not prepping the lateral incisor, so we're using a 57 to break the contact here. This will give us a 90-degree angle when we've broken the contact at the margin, and we'll go ahead and round that off with our burr in our final margination towards the end of the reverse preparation technique. We're now doing our incisal reduction with the MADC burrs. All of these burrs are available on the reverse preparation kit from Axis Dental, and we love that technique here in the laboratory because it ensures that we always get enough reduction and can give you back the best looking restorations. So 2mm depth cuts are placed on the incisal edge, and then we reduce that. We're accelerating this sequence. If you'd like to see more, we have a whole DVD on the reverse preparation technique available online, or available to have a DVD sent to you here from Glidewell Laboratories. We finished the technique, and we're trying in the Biotemps bridge now. And when you try in a Biotemps bridge, you would really ideally like to see it seat very passively, and that's what we're checking here to make sure that it goes down all the way and seats passively, and we want to see that the margins are sealed or almost sealed on the 2 abutment teeth. We are going to reline this with a methyl methacrylate. At this point, we have relined the Biotemps bridge with the methyl methacrylate and trimmed the bridge to make sure that we have no flash at the margins and that the contours in the gingival third are where we want them to be. We want to make sure we don't have any bulky margins at the gingival third. In fact, we'd like to almost have a flat or a reverse contour there. So rather than having to be convex, we'd almost rather have it be concave at the margins. Now that we're getting ready to cement it, we're checking the occlusion, and we're going to go ahead, and my assistant is actually removing some of those marks where it's hitting a little bit too hard, and once we've had a chance to do that, we will polish our Biotemps bridge. If we want to put the glaze back on it, we can use a little Palaseal from Heraeus Colzer and paint that onto the Biotemps bridge and then light cure that, and that will give us a nice glaze back again. We have now placed the Temp-Bond into the Biotemps bridge, and we're pushing it into place, and you can see that now it should go down all the way and the margin should be closed, and that's just going to take a couple minutes for that to set. So again, because of the tissue and because of the recent extraction sites, the tissue was not healthy enough to take an impression today, and I'm committed to not taking an impression unless we can really get an almost ideal or an ideal impression. So I never hesitate, if the tissue doesn't look as good as I think it can, to wait and take the impression at a later appointment. It always pays dividends down the road with better looking restorations and certainly better fitting restorations when we can take impressions in hopefully a blood-free environment or with the least amount of bleeding possible. So the patient is sent home at that point with us planning to take impressions at the next appointment. And here we are at the next appointment. The first thing we're going to do is remove the Biotemps bridge and take a look and see how the tissue is doing, hopefully being able to impress those abutments today. And as we take the Biotemps bridge off, I can see the tissue looks pretty good around our abutments. I can see a little debris in one of the healing extraction sites, but the tissue looks a lot more pink and a lot healthier than it looked last time. So I think we're going to be able to impress this today. We're going to go ahead and clean off the temporary cement and start to pack some cord around these teeth. We'll be using the 2-cord technique, which is my favorite technique. We've talked about it on almost every restorative procedure that we've done on our educational DVDs, and it's still the one technique, even though it does take a lot of work, that always works for me and produces the best impressions and therefore the best restorations. If I found an easier way to get the same results, I would certainly do it. We floss the 00 cord. This is an Ultra Pack 00 cord from Ultradent. We floss it through on the mesial and floss it through on the distal, and then pull the two loose ends toward the lingual and leave a little bit of extra slack in the cord on the facial so I can use this cord packing instrument to help get the cord subgingival here. And you can see already the gingival margin moving back a little bit as we place this cord, and that's one of the nice things about this cord, is that it atraumatically exposes the margin for us. We can also place our number 2 cord at this time if we choose to do so. This is a 2E cord, Ultra Pack cord from Ultradent. And we put this cord in before we drop the margins because I do want this margin to be a little farther subgingival than usual because of the patient's propensity for getting recurrent decay. So what we're going to do then is take the larger chamfer burr from the reverse preparation kit, the 856-025, and drop the margin down this last little bit to where the gingiva is now. That way, when the 00 cord is taken out, the tissue will move coronally so that the margin for our crown, or in this case our bridge, is going to be just slightly subgingival. Most of the time I try to leave our margins at the gingival margin or just slightly subgingival, but this patient on some of his other restorations has shown that he is definitely susceptible to recurrent decay, and that is one of the legit reasons to drop a margin a little more subgingival than you ordinarily would. I still don't want to have any biologic width violations, so we're going to be very careful interproximally not to drop the margins too far down. And we're just taking this 856-025 burr and running it along and just dropping it down almost to the gingiva. Again, our goal is not to cause any bleeding here on that gingiva, so we're going to go to great pains to make sure that we don't cause any bleeding by nicking the gingiva with a burr and a high-speed handpiece. After the patient bites down on a couple of compra caps for 8 to 10 minutes, we remove that top cord, that 2E cord. You can see how wide open the sulcus is, for example, on both of these teeth, and you can see it on this cuspid as well. And as we go around and syringe around both of these teeth, we're using a medium body material because of how wide open that sulcus is. Furthermore, on the 2-cord technique, because there's no bleeding, we should get an impression of the entire sulcus as well, down to the level of that 00 cord, which is still in place. And that's why I like a medium body syringe material, because it tends not to tear as much as it comes out of the patient's mouth, especially the part that's gone subgingival. And a light body material is nice, and yes, it flows a little better, but it does tend to tear more subgingivally. And I really do want that impression of root structure from the impression material that goes subgingival to be able to get a really good emergence profile. You'll see we're using a custom tray here. It's a good idea in many crown and bridge cases, and it's absolutely mandatory for me on these combination cases that we be able to use a custom tray. This is what you should see with the two-chord technique. You should see a nice margin from the reverse preparation technique that goes all the way around the tooth, and you see that extra fin of material extending into the periodontal pocket, into the sulcus, I should say. And that's going to give some important anatomic information to the technician to show them not only where the root is, where the end of the margin is. You can just see how clean that margin looks all the way around. And because we've impressed beyond that, the technician knows for sure exactly where the end of that margin is. If the end of the impression is the end of the margin, they're always guessing. You can see how thick that material is as we move around circumferentially on that tooth, because the material was butted up against that 00 chord. And I'd much rather see that than have a thin kind of flash material down in the bottom of the sulcus, because you'll see that area, those fins actually bend back and forth as you pour dye stone into the impression. We're going to go ahead and take a bite registration here. Again, when taking a bite registration for a crown and bridge case or a combination case like this, all we want to do is get the bite registration on the teeth that have been prepared and on the opposing teeth. And as we take this out, this is what it looks like as it comes out of the mouth. We're going to trim that back with a scalpel. Really all we need on the bite registration is the incisal third of the preparations, and on the other side we just need the incisal third of the opposing teeth. We don't want any soft tissue contact with the bite registration.
I had the opportunity recently to speak to some of our combination department technicians, and they had a few suggestions regarding bite registrations. One was that you always provide a model of the patient's pre-op condition that goes back and forth and travels back and forth with the case. Many times in bite registrations, we can actually jump the bite off of these pre-op models using some of the soft tissue landmarks. It's also very important that we have a model where the temporaries are cemented in place. That's a very nice model for us to have, especially if we're dealing with a collapsed bite and you've used the temporaries to re-establish the correct vertical dimension. We really need to be able to see what the temporaries look like in the patient's mouth to help determine how we are going to build this combination case for you.
Having taken an impression that we're happy with, we're going to go ahead and replace the biotemps now, again putting them in with Temp-Bond, and we'll send that off to the lab. It's going to be a straightforward PFM bridge for the combination department. There's no attachments. But the reason that the combination department has their own ceramists to make these types of crowns and bridges for these combination cases is they are extremely well schooled in what kind of contours we need for clasps and for rests and things like that. And that's the reason why we really have a competitive advantage as a combination lab, because we have our own PFM department within the combination department. The prescription we receive from the combination department calls for some clinically prepared rest on the lower teeth, and we're placing these now. Again, I'm placing this with a round burr, the way I was taught to do in dental school, and as you'll see in this DVD, that's not the way that the combination department wants to have them placed, and it's because of the undercuts that the round burr can leave when you insert it deep enough to get enough thickness so that the metal rest will have adequate strength. And as you'll see later in this DVD, we use an 845 KR 018 burr, an inlay burr, to prepare these, a modified shoulder inlay burr, which will eliminate any of the undercuts that could be caused by the round burr. And as we look at the rest preparations here in this mirror shot, they appear to be okay, but you really need to see them in the stone model. That's really when you can tell when you've got the presence of an undercut. It's a little difficult to tell in the mirror, and that is in fact what the lab found, and they had me re-prep them with that inlay burr. We've got our custom tray here. It's perforated, and my assistant is painting some adhesive on the inside of it, so we get a little chemical bond in addition to the mechanical bond that we get from a perforated custom tray. And we will be taking our master impression of the lower arch, since all we had to do, according to the prescription we got from the combo department, was to prepare rests on either side, and they were going to go ahead and make a conventional partial for us after that. So in and around the rest preps, I'm going ahead and injecting some light body material because I know it's going to flow well into those rest preparations and around the teeth that will be clasped. And then in the impression tray itself, my assistant has filled it with monophase material, and we're placing the monophase in because that's going to give us a good impression of the two residual ridges distal to the first molar without displacing any tissue. We remove the impression and take a look at it to make sure everything is where it should be. So it's time for the next appointment, and we remove the patient's biotemp bridges again. We've got even more healing in those socket areas, and tissue still looks good. We're trying in our PFM bridge here to make sure that we have a nice fit with the bridge. We can see we've got a little tissue pressure here. When I push the bridge down into place, it looks nice. So I take my fingers off it. The tissue pushes the bridge away a little bit from the teeth. And I actually like that. That's, part of what my plan was with the two-chord technique and with the subgingival margins. I knew that we would have a little tissue rebound here, but that's what I'm looking for. I want my margins slightly subgingival. I want the bridge to have a nice, tight, intimate fit against the gingival tissues. Here's a mirror shot of the lab-prepared rest that you can see on the lingual of tooth number 6. Again, when you prepare the tooth, if it does call for a lab-placed rest onto a restoration like that, you may want to place a little rest preparation yourself into the tooth, into the preparation when you're done prepping the crown, just to make sure they have enough room to incorporate that rest into the PFM itself. It's now time for the upper pickup impression. Pickup impression, of course, referring to any time we've got a crown and or bridge in place and we're going to pick it up in the impression. This is really critically important in these combination cases. One of the biggest mistakes that I see looking at these cases is dentists who want to jump the gun and cement a bridge like this into place and then take the impression and send it to the lab and have them fabricate the framework for the partial denture. And while theoretically this could work, really the best way, the right way to do it is to pick up the units, or in this case the bridge, in the pickup impression and send it to the laboratory in the impression so they have the actual bridge to work with when fabricating the partial. To make sure that tissue rebound doesn't play any part in this pickup impression, we have cemented that bridge into place with temporary cement. And you can use that or Duralon cut with a little Vaseline, and that's going to make sure that the bridge does not move at all during the pickup impression. That is the biggest problem with the pickup impression itself. As long as you have the bridge nice and stable on the abutments and take the impression, things should go real smoothly. If you just try to set the bridge in place and take the pickup impression, the lab's probably going to call you and say they have some problems with it fitting back onto the model work. Now we've got the restorations back from the lab, and we're taking a look at the framework here. We can see the anterior tooth that was added on. We can see the clasping, pretty straightforward clasp. So we've got a shoulder back action clasp on the molar on the upper. We've got a roach clasp around the bicuspid. On the other side, we have an Akers clasp. And you can see our occlusal rest. There, in fact, is where the crown on number 6 has that lab fabricated rest, and you can see the metal framework that accompanies that on the partial. It's going to sit on top of that rest and prevent the tissue from sinking in there. On the lower one, again, we have a pretty straightforward partial here with clasping on the 2 first molars and then the 1 missing tooth. You can see the occlusal rest where we prepared both of those. Again, it's important to use that inlay burr rather than a round burr and give the lab enough room to make an occlusal rest that's going to be strong enough to withstand chewing, where you're not going to have to adjust any of the opposing teeth, and you're not going to have to grind on that occlusal rest till it's so thin that it breaks. Even though it's a conventional partial, the arms of the clasps are kept down over the gingiva, so that when the patient talks, hopefully we will not see too much of the clasp. So even though we didn't go with a precision attachment, we want to make sure that we show as little metal as possible whenever we can. So we're going to go ahead and remove the Biotemps bridge at this point. We've got some cement stuck to that central incisor on the facial, and just a little I can see in the mirror as well. This was Duralon that we put this off with because the patient had the temporary bridge fall off, so we went back on and put it on with Duralon, knowing that it would not come off. And it's sticking here, and you have your choice. You can use the Cavo Sonic Scaler to take it off. In this case, I'm using a 1-gloss wheel from Shofu, and this will not affect the tooth structure at all. We're just polishing that excess cement off of here, so when we put the PFM bridge back in now, we won't have any temporary cement interfering with the fit. And typically, if you do inadvertently leave temporary cement on and try the restoration on, it will look like there's an open margin when in fact it was due to the temporary cement. And I wear loupes during this procedure too, which is really helpful to be able to see those areas where we may have some excess temporary cement. So we have the Bridge in place. It's been tried into place, and now we're trying in the framework with it as well to see what kind of fit we have. And snap this little guy in there. Again, the bridge is not cemented, so you can see we've got a little tissue rebound there as it moves. But as I hold it into place, really what I'm looking for is to see how the clasp on the cuspid fits and if, in fact, it does engage the undercut. And it does. And we're trying in the lower partial at this point as well. Snap that in. That should be really straightforward. There was no real recontouring of the teeth that was necessary, just those clinically prepared rests on the occlusal. And things look nice. Again, just making sure that everything is down into place where it's supposed to be. Since everything fit at the appointment where everything was in wax, we're going to go ahead and cement this today, cement the bridge, and deliver both the upper and lower partial denture. So we are now ready to cement the upper bridge into place, and we'll go through our usual cementation technique. We will clean the teeth with our pre-packaged pumice. This is the Preppies from Whip Mix that you've seen us use before on DVDs, and the Concepsis from Ultradent to make sure we've killed all the bacteria that may have gotten on the teeth. And we are now seating the bridge with Reliax Luting Cement Plus. Again, I'm using the orange wood sticks to help push this into place. And I will hold it down a little more, but I want to get the partial in as quickly as possible once the bridge is into place to make sure that the clasp on the cuspid and everything else is in good relation to the bridge itself. And now I'll hold the bridge down the rest of the way with the orange wood sticks as it goes through the rest of its setting reaction. Of course, one of the great things about 3M SP's Reliax Luting Cement Plus is the ease of cleanup. So we're going to clean up everything we can reach on the facial and the lingual while we allow the cement to continue to set. And then after that, we're going to very carefully take out the partial denture and then clean up all the areas we couldn't get to where the cement was under the partial, and then we'll go ahead and place the partial back in to confirm that we do have the fit. You'll see on some of the other cases on this DVD where we have attachments that we actually insert it all as one piece. We literally engage the attachments on the crowns and the bridges with the female attachments on the partials and put it all in as one piece. Here, because we don't have that precise of a fit, we just make sure that we put that upper partial in while the cement is still setting so that we make sure we have the correct relationship between the crowns and between the clasps on the partial denture. We've delivered the lower partial as well, and now we're going to go ahead and check the occlusion and have the patient bite down on both sides and see how it looks. Visibly, you can also look to see when the patient bites down if the clasps move at all. Obviously, that's a sign it's high. You could see there on that natural bicuspid, we had a nice occlusal mark there, and that's what we want to see is the unprepared natural teeth hitting just as hard as we're hitting on the partial denture itself. We're going to recontour a sharp little area on a lower cuspid here with one of our one gloss discs. And then we're checking one last time, and I see a spot on the lingual of the bridge that needs a little bit of adjustment. So we're using a 7408 Carbide burr to do that. And you can see afterwards, here's the patient in a studio portrait, how excited he is about this. Although he had a big smile even when his teeth were all bombed out. But you can see how much better it looks. In the lateral view, you can see just a little bit of the clasp. You can see just a little bit from the front, but the patient is extremely happy. You can see when you compare how he looked on his smile before to how the smile looks now, that even though we have a small amount of metal showing on the conventional clasps, it's still a huge improvement from where he was before. And keep in mind that this is a big maximum smile as we're trying to take a photograph. And this is not his typical smile when you see him and you just bump into him walking around. He smiles a little bit smaller and you see even less of that metal. And yeah, we could have used precision attachments on this and hit it completely, and you'll see us do that on the other two cases. But we wanted to make sure one of these cases represented just a straightforward conventional partial, because we still see a lot of those come through the laboratory. Even with the metal that shows when the patient smiles like he is smiling here, the patient was thrilled with the outcome of this treatment.
I'd like to spend a couple of moments talking about a really important concept in combination dentistry, a procedure that we sometimes have to do, and that is the fabrication of a PFM crown under an existing partial clasp. Now, there's a few ways to deal with this when we have to make a new PFM crown under an existing partial. One way, option number one, would be to fabricate a new partial. So if we have an older partial denture that has some problems with it anyway, teeth are worn down and beyond repair, clasps are broken off, something like that. This is an ideal time to make that new partial. The laboratory can construct the new PFM crown for us and then make the new partial around that, and you will have a great fit when you go back to the patient's mouth. The second option is to have a spare partial. A lot of times this is a partial denture that is processed a little more quickly. It doesn't have to be as expensive as the patient's original partial. Some patients even just have a flipper, but I prefer a spare partial for times like this where it has to go to the laboratory, or in case of breakage, especially if the partial has some anterior teeth on it and the patient breaks them off and doesn't want to be seen like that, or one gets lost or misplaced. A spare partial is always a nice thing to have. The third way to do this would be to send the partial denture to the laboratory, and then the laboratory would actually have the partial when they were making the PFM crown underneath it. And this is a great way to do it. Certainly makes it easy for the lab and makes it easy for you because it's going to fit well when you get it back. But always remember, if you're going to send a partial to the laboratory, you need to send it in a pickup impression. If you simply take a crown and bridge impression and send the partial to the laboratory, it will not fit on any model. The only model that the partial denture will fit on is when the partial denture is picked up in what should be a full arch pickup impression. And the fourth way, the most common way, is what we call an adaptation pattern, or a pickup impression with an adaptation. And that's what I'd like to spend a little time showing you right now, is how to do that, because a lot of patients don't want to surrender their partial denture. So for example, we have a patient who's going to have a new crown here on a first bicuspid. Tooth has been prepped. You look at it and it looks nice. One of the first things you want to do is try the partial in after you finish the preparation. And in the patient's mouth, look to make sure that you have, in fact, done enough reduction so you're going to have room for the PFM crown. So as I look down on this prepared tooth right here, I want to make sure that I have enough reduction between the tooth and the clasp on the facial and the lingual. I want to be able to look down and view occlusally and make sure I have enough occlusal reduction so that the occlusal rest is going to be able to have the porcelain metal underneath it that it needs. And then you want to also look at it from a buccal angle so you can see that there's enough room. We've got a guide plane here in our framework, and we want to make sure there's enough room to have the proper contours of the crown. So the first thing to do to check your reduction is just put the partial framework back in again and verify that you do, in fact, have enough reduction. It's a little easier to do on a model like this, where we can put it into place and we've got class on the buccal and lingual and just a small occlusal rest coming off the mesial. And again, the key is to look in and verify, take your Explorer and run it through there and make sure you have plenty of room between the preparation and between the clasps, or in this case the occlusal rest as well, for the laboratory to fabricate this PFM crown. Once you verify that you have enough reduction, we want to go ahead and take a pickup impression. Now, one thing to really keep in mind when taking this pickup impression is that the partial needs to be all the way down against the tissue and the claps need to be engaged all the way against the teeth. You really want to make sure that the partial is not up. You'd be surprised how many impressions we get where at some point during the impression taking process we actually have the partial lift up a little bit in one area or the other, just like that. It might just come off just a slight bit like that when the impression's being taken, and it's ruined it and needs to be retaken again. In fact, one of the things I like to do, if you look at this model, for example, we're going to use a full upper arch tray, and I'll drill a hole. I'll take a plastic tray and actually drill a hole through the palate and then try in the plastic tray in the patient's mouth so I can see the metal of the palate, the framework, through the hole in the impression tray. And then when we go in and actually squirt the material, as we'll do here in just a minute, around the clasp and underneath the guide plane and around the preparation, when we seat the tray in the mouth, I will take my finger and push it through the impression tray and push down on the palate of the partial denture as the impression tray is in the patient's mouth, just to make sure that it's fully seated. It's very easy for these to become dislodged, especially when the main tooth that's being clasped has been prepared here and we have no contact between the clasps and the preparation itself. So it all depends on how much retention you have on your other clasps in the arch when you go to take that impression. So a great way to do it is to cut a hole in that upper tray and put your finger through it and hold it in place. Of course, on the lower, we would do the same thing by cutting a hole here in the back, seat the tray, and then be able to take your finger and push and make sure that lingual bar is seated all the way against the tissue. It really is much more common than you might expect that we have some displacement of the partial denture during the pickup impression. Doesn't seem like it because we're seating the tray down this way, but you've got to believe me, it happens more than you would think it does. So make sure you have a way. If you don't have that kind of snap-in retention where you hear that audible snap when the partial goes into place, leave yourself a way to make sure you can verify and push down on the partial framework and make sure it is in fact down all the way when you take the pickup impression. So to actually make the adaptation pattern, we're going to make sure that the partial is seated all the way into the patient's mouth, that we're down in all of our occlusal rests, and that our framework is down on the palate as well. And then we're going to go ahead and just express material underneath the clasps, around the preparation, and then around all of the clasps and the occlusal rest and the guide plane as well. So basically we want to fill the entire area underneath the occlusal rest and the clasp with impression material, and then just continued kind of like soft serve ice cream just to go around the tooth and build it up. You really can't build it up too much here because the laboratory is going to trim it down later. And the key here is just to make sure that you get the bite registration material all the way around the tooth preparation and all the way around all the parts of the clasp as well. So let's go ahead and begin to express some here. I'm going to start under the occlusal rest by the guide plane, just squirting it in. I like to see it come out the other side. I like to see it come out the bottom. Then I'm going to come around through the interproximal area. Again, I'm going to keep the tip, try to keep the tip between the clasp and the tooth preparation. And then I'm just going to squirt some extra material down so that I cover everything. The key is to cover everything on the partial having to do with that clasp and the tooth preparation. And then this one's a little easier to see. We're going to go ahead and do our lower model. You can see real clearly there the amount of reduction that we have. Again, we're going to start interproximally. I like to start and just squirt it in until I start to see it come out to the sides and the top. And then keeping the tip in the material, working our way around, trying to keep the tip between the tooth and the clasp, going around the tooth, and then covering up the rest of the preparation, doing some extra all the way around just to make sure that the preparation and the partial are completely covered. So we now have an impression of the inside of the clasp, and we can make a resin pattern or we can make a pattern in several different ways. But this little adaptation pattern that we have will now allow the laboratory technician, just like this, to make a clasp. This isn't the perfect way to do it. It'd be much better to take a pickup impression and have the actual partial sent to the laboratory. But we know realistically there's a lot of patients who won't give up their partials, and it becomes necessary to do an adaptation pattern like this. If you give us an accurate adaptation pattern like this, you're going to get a pretty darn good fit back when you get the crown and the partial, when you get the crown back to your office and then trying the partial over it. And you may have some minor adjustments to do, but certainly you're going to have a great head start in it. Most of the time, my experience has been they fit with no adjustments at all. Let's take a look at our other model. And we'll go ahead and try the adaptation pattern onto there. Again, looking into the inside, you can see we have a good impression. Some dentists prefer to squirt the registration material around the tooth and then seat the partial. I've had just as much luck with the partial in place, verifying that it's down. Sometimes I feel if you put the registration material around the tooth and you put a lot of it and push it down, you might get some underneath the saddle area and keep it from going down all the way. So I prefer to seat the partial first and then squirt the material in. And as I turn this to the side and the camera zooms in, you'll see here that we have a nice representation of that clasp right along the bottom of this. They could almost put resin directly into that and have a representation of that clasp. So let's try the partial back in again just to visualize what that looks like. And make sure it is down all the way. And again, if we look at it from the occlusal, you can see the occlusal rest fits right in that preparation. It really doesn't matter what it looks like up here. In fact, you don't need to trim this area. We'd prefer you keep it thick just for strength. And we'll look here at the buccal. Again, that area that I pointed out to you before, you can see the clasp fits very intimately right into there. And as we take a look at the lingual, we have the same thing where the clasp is fitting into that indentation perfectly. So we can take the partial out, leave it with the patient, send that adaptation pattern to the laboratory so they can fabricate a resin analog of the clasp and help make a PFM crown for us that's going to fit really well underneath that clasp. As with all of our patients, we've gone ahead and used the Glidewell design service, and even as you get a lot of knowledge about combination crown and bridge cases, this is really helpful because they can survey the models and take a close look and let you know exactly which attachments they think are going to work best. For example, on this patient, you can see on the upper model, they have put in the design a cross-arch roach ball attachment, which is an interesting attachment. This is one that most dentists have not had the opportunity to use in dental school and practice afterwards, where you actually have a roach ball. It's a metal ball that's cast onto the partial itself and gets inserted into a female area in between these two splinted crowns. Actually, these are all going to be splinted together, but this is a good example of an attachment that most dentists wouldn't think to ask for on their own. So this is kind of a difficult situation. We've only got 4 teeth left, and they're going to be splinted together with crowns. And so we're going to gain some of our retention here with this crotch arch roach ball. We've got a VKS attachment here that's going to have a female on the underside of the partial, and then we've got a rest prep here that the laboratory is going to prepare, as you see, so we don't need to worry about that. We just need to reduce enough on the cuspid to make sure that they have enough room for the rest. So typically what I will do is prepare the crown and then prepare the rest into the crown preparation itself, thereby ensuring that the technicians have enough room to make a PFM for us with the rest in place as well. Sometimes if you just prepare the tooth for a PFM, that will not be enough space. So even in a case where we just have these 4 teeth left on one side of the mouth, the design team has come up with a design that has no metal showing. Our 2 methods of retention here are the cross-arch roach ball and the VKS attachment, and then we just have mesh and teeth the rest of the way. And it's a really nice design. Aesthetically, there's not going to be any clasps or any metal visible from the facial. So the patient's going to be very happy with this. So that's what the upper model looks like. Of course, they draw this on the model and send it back to us, but they email this to us so that we can see it and make turnaround time a little bit quicker here. And then we move on to the lower model. And again, they've done a design for us that takes into account the patient's concerns not to have any metal showing. We have a VKS attachment here, a VKS attachment here, 2 splinted crowns over on one side of the mouth, and then we've got a cast crown over a PFM on the other side of the mouth, again with the laboratory prepared rest on both of those crowns. And so again, we've accomplished the patient's concerns of not having really any metal showing. As you'll see on this partial, the way it's designed, we're going to have an attachment coming off the back of each of these crowns with a female on the underside of the partial, and you will not see an eye bar or any kind of clasp on the facial itself. And it's a nice way to be able to design that. Most dentists aren't exactly sure how to design a case like that if they don't want to have any metal clasps showing. Couple different views here so we can see what's going on with the attachments. Sending the models to the laboratory gives them a chance to be able to measure this, make sure there's enough vertical space here. Sometimes there needs to be some tissue recontouring done. Sometimes the prep has to be built up a little bit to make room for those attachments. We have some technical notes from the laboratory about things they want us to watch out for, which is a nice way for them to be able to express any concerns that they have or anything special that they want us to do. And then the nice part is we get an estimate of cost on this as well, and they go through for us and add up the PFMs, the rest preps and the crowns, all the connectors, anything that needs to be done in terms of labor. And so we have an idea, we know what our cost is going to be here. It's going to be $2,000 for the lab work on all of this. And this makes it a lot easier for us to now give the patient a better idea of what it's going to cost. If we simply tell the patient that it's going to be the same as a regular partial denture and use our regular fee for a complicated partial like this that's going to have several attachments and no metal showing, it's probably not going to be fair to us and maybe not fair to the patient as well. Here we have an exact idea of what this partial is going to cost, and then we can work backwards and figure out what our fee needs to be for this partial. It's going to end up being more than just a regular, simple, straightforward partial, but it's going to allow us to be compensated fairly for this and give the patient the partial that they really desire.
This patient presented already having a flipper in place that he was having problems. It kept falling down on the right-hand side, and rightfully so. He only had 4 teeth left, teeth number 11, 12, 14, and 15. And so all the remaining teeth in his maxillary arch were on the left-hand side of his mouth, so the flipper on the right-hand side continued to fall down. I sent some study models over to our combination department, and they felt that even a standard partial denture would probably not be enough to retain this on the right-hand side for this patient, so it was decided to use a combination approach. But in a case like this where the patient has a pre-existing flipper that he wants to wear home, we're going to go ahead and take a polyvinyl siloxane impression of those teeth and make some chairside temporaries with the same contours as his original teeth so that he can wear that prosthesis home. So even though it doesn't fit really well, it still looks better than having a huge hole in the front of his mouth. So you see us taking the pre-impression here for the chairside temporaries. Once that has been accomplished, we are now going to start our typical reverse preparation technique. The first burr being used is the round burr. This is an 801-021 burr. Now that we're done preparing the teeth, we're going to go ahead and reseat our original polyvinyl siloxane impression with the bisacryl material. This happens to be Luxatemp in place. And we're going to let this sit in place for about 60 seconds, remove the impression, and see how our temporaries look before we begin to shape those. Again, the goal of using the chairside temporaries today is just to make sure that the patient can leave wearing the flipper like he did when he walked in that morning, so he doesn't have to be missing all his front teeth when he gets up and goes out tonight or goes to work tomorrow. And there's the bisacryl inside that pre-impression. And so we're going to trim that up, and we have cemented those into place with some Temp-Bond, and then back into place goes his appliance that he came in the door with, and we'll kind of seat that into place, and hopefully that'll snap into place and give him a little bit of retention. And he appears to have some retention, but you can see a lot of wear on those anterior teeth as well. You can see the tetracycline staining on his lower teeth as well. And we present to him the option of doing veneers, but he chooses not to do it at this time, although by the end of the case he does want to do it. Here is the upper bite rim that we're putting into place. This is really, on a case like this, the only way to get a good bite. We see a lot of mush bites in the laboratory here. An example of a mush bite would be just squirting impression material into his upper arch and having him bite down on it. That's about 50% of the bites we get, and that just makes it so difficult to try to seat that impression material on the stone model. Whereas with these bite rims, they're going to fit against the residual ridge, fit up against the remaining teeth into the lingual undercuts. That's pretty darn stable when I put that into place. And you can see I've heated up the wax now, and he bites together such that tooth number 11 is touching the lower cuspid, tooth number 22. So I know he's all the way together. So it's nice that we have those two teeth, the temporary on tooth number 11 and on the natural tooth on tooth number 22, so we can see that he is in fact in maximum intercuspation. Here I'm using a little cool air just to cool down the wax a little bit and get it to set up a little more quickly as we have his lower teeth biting into that. And this is the kind of bite registration that the laboratory can definitely reproduce in a situation like this. But to use that mush bite, just use rolled up base plate wax or bite registration or some other sort of polyvinyl siloxane impression material, and for them to try to get it to fit on their ridge just isn't going to work. This bite rim goes up and over the residual ridge into the palate against the lingual of those teeth that we have prepared. And really there's only one way it can fit on that model, especially when you bring the lower jaw into play and try to fit those lower teeth into the bite registration. So this is really the one right way and the best way to get a bite registration here, and I want you to resist the urge. The third thing, if I could teach you a third thing today on this DVD, is to resist the urge to use mush bites like that. Of course, as long as we have the bite rim in, we're going to take that opportunity to mark the maxillary midline for the laboratory, so that when they set the teeth up on this rim, they're going to know where teeth number 8 and 9 should go. So we've marked that for them. We can clearly see the marks from the opposing teeth in that bite rim, and that's what we like to see. We have a lower bite rim as well that we're going to put into place, and this one is not always as stable as the upper bite rim. I have the patient bite together as we did on the upper one before we heat up the wax at all, just to see how much wax needs to be removed before we get started. We just want to get an idea of how close we are. You can see I've softened that up with a hot lab knife now, and I've softened it about halfway through the rim, which I think is going to be deep enough, and he's going to bite together and squeeze, and boom, I can see tooth number 11 and tooth number 22 touching each other there, telling me that he's all the way down. And of course, it sticks to the upper when we try to do that. Now, over on the lower right, where it's edentulous and there's no natural teeth, I'm going to have to heat up the wax and get him to bite together. You can see when he bites down there that he bites right back into that bite rim again. And so I can tell for sure that that's good. Now I've heated up the lower right-hand side of this bite rim. The left-hand side, we can already see the teeth marks in there, and that should come together. But when he bites together now, what I want is the right-hand side to come in contact with the upper bite rim. And it has. So as he bites together here, I can see teeth 11 and 22 are in contact, which is good because we're at the correct vertical dimension. I can see the upper teeth on that side are in the bite rim, the lower anterior teeth indent into the upper bite rim. And now on the right-hand side, we have the upper and lower bite rim pressed against each other, which typically means it'll come out in one piece as it did here. So when it comes out in one piece, as it does here, I'm pretty darn confident with this bite. In fact, I know I can put it back in his mouth and have him bite right into it. So I'm going to send it over to the laboratory in one piece here so they can mount those two models and articulate them. And I'm very confident about that bite. And that's not always true when you only have 4 teeth. At this appointment, we're now going to take our final crown and bridge impressions for those teeth. I put those temporaries on with Duralon to make sure they would stay on and not go anywhere because that partial grabbing onto them that the patient already had. This is the Cavo Sonic Scaler being used to remove the Duralon, the polycarboxylate cement from these teeth. Without a sonic scaler like this, you could take a hygiene scaler and scrape for hours probably trying to get all the Duralon off. I know I've tried that before until a friend told me about the Cavo Sonic Scaler, which does it literally in seconds. This is the first chord of the 2-chord technique. This is the 00 chord. We're going to place a number 2 chord. This is a 2E chord, ultra pack chord. We have light body material that's been squirted around those preparations, as you can see here, and then monophase material has been used in a perforated custom tray, and we put that into place. Why? Well, the light body material does a good job of capturing the margins, as you can see, and the monophase material does a great job of capturing soft tissue contours, in and around other parts of the arch. If you have more questions or want to see this prep technique in more detail, you can go online and look at our reverse preparation technique in our continuing education section, or call Glidewell Laboratories and have the reverse preparation technique DVD mailed to your office, and it's good for CE credit as well. Time for the next appointment. Patient comes back again, and we take off the temporaries, clean up the teeth, and it's time for us to try in the restorations and see how it fits. And there's a close-up look on the lingual of the cross-arch roach ball. There's the female part of that attachment that the male is going to fit into. You'll notice that it fits right between tooth 14 and 15 where those two crowns are splinted together. In fact, the lab made a note for me to make sure I prep a little extra space between those two teeth to have room for that. And you can see the VKS attachment coming off the mesial of tooth number 11 right there. Again, if the patient were to bite together right now, they would need to have 5 millimeters of space between the gingiva there and the opposing tooth, the opposing incisal edge, for us to fit a VKS attachment in place. So when the patient were to bite down here and hit tooth number 11 against tooth number 22, there would need to be 5, possibly 6 millimeters of vertical space between that adjacent residual ridge and the incisal edge of the teeth across from it to make sure we have enough room for the attachment, the framework, and the partial that's going to go on top of it. Again, if you send the models to our combination department and let them, design it for you and send it back to you or email it to you to see if you like it, they will never recommend an attachment in an area where there's not enough room for it to be placed. So our combination and design service goes a long way to helping you decide what's the best way to be able to do something like this. Since all the units fit when we try them in, the Splinted Crowns on 11 and 12 and 14 and 15, it's time to cement them temporarily. Again, that's one of the huge things I want you to learn from this DVD is you must temporarily cement these crowns into place. Feel free to put some Vaseline in if you're using something like Duralon. And then we're using light body material around these crowns and around the attachment. This is, of course, going to be a pickup impression. And at any time during the impressioning technique, you'll notice we're using custom trays. And we really would like to encourage you to use custom trays anytime you're taking an impression in a combination case like this. We see a lot of stock plastic trays coming in instead of these custom trays, and it's just not the same. These are trays that are custom designed for this particular patient and takes all of his anatomic structures into account when it's taken, and you just end up with some excellent impressions in the custom trays. rather than the stock plastic trays. It's one thing to use the stock plastic trays for the study models, but once we get beyond that point, custom trays are the way to go. And we would also encourage you to not use heavy body. Again, heavy body material just pushes tissue around, and it's not a good idea. As you can see right here, I'm injecting our light body material around the crowns for this pickup impression, and that won't do anything to the tissue itself. But when you use the heavy body material, that can tend to push tissues out of the way and give you a distorted ridge, and you'll end up with a partial where the ridge comes in contact just a little too much with the underside, the tissue side of the partial. So the custom tray is being seated here with the monophase material inside of it. Again, if you look at that ridge on the lower left, you can see how nice that ridge turned out. And again, there's no impression material between the crown and the tooth. As you look up this pickup impression, I can see the tissue side of the VKS attachment as well. And so we've picked up everything we need to pick up on the lower. Here's the upper one. Again, you can see how the monophase does such a good job in contact with the tissue. And again, there's no impression material under any of our upper crowns. So resist the urge to cement these crowns, leave them in the impression, and now send them to the laboratory so they can fabricate your framework. And here we are at the next appointment, and here is the framework. You can see that cross-arch roach ball on this as we're trying it in. And we have a wax rim on our framework. And I've got the crowns in place on 14 and 15 and 11 and 12. And we engage that cross-arch roach ball, and we want to make sure that things look good here. So we're having the patient bite together into the wax rim. And we again have got our lower in wax as well. Our lower framework has been made, and the crowns are in place on the lower. I'm pushing this down, seeing if I can engage the attachments in there. If I can't, I'll take it out and engage the crowns right into the attachments themselves and then try it back in together, which I'll often do right off the bat. Sometimes I'll try it this way first if the crowns happen to be in the mouth already, and if not, we'll just put them in together as one unit. I've cut a few notches in this upper bite rim so I can put some bite registration material here and have the patient be able to bite together. Again, any chance we get to kind of update the laboratory with a fresh bite, it's a nice thing to be able to do. The main purpose of today's appointment is for me to check the framework and make sure that it fits, make sure that the attachments are working as they should, make sure that the male going into that cross-arch roach ball attachment is fitting as it should as well. But as long as we have the opportunity, we're going to take another bite to kind of re-verify for the laboratory where this patient bite belongs. And you can see now when we take it out, we can see the cement inside those upper crowns. We flip it over, we can see the cement in the lower crown. So yes, it does make it a little messier. You can see the VKS attachment attached. The male is into the female at that point, and that's what we want to have for the pickup impression. So you need to make sure that we get real accurate pickup impressions by cementing the restorations into place and using custom trays. Now let's take a closer look at our appliances. We have them back from the laboratory, and they've been processed and finished. Again, you can see that cross-arch roach ball there on the posterior going into that area right here between number 14 and number 15. We have a rest on the distal of the crown on tooth number 11. You can see the female attachment for the VKS attachment. That was coming off the mesial of the crown on tooth number 11. So really, again, kind of like the other case that you saw before this, most of the metal is in fact hidden, which makes it a very aesthetic partial denture. So in addition to replacing a lot of missing teeth for form and function, these cases can be very aesthetic at the same time. You can see the same kind of aesthetic improvement that you would see on patients from a veneer case or something like that. So these fall within the realm of aesthetic dentistry, at least in my mind. And because of the two attachments we have on the lower, we're going to have a very aesthetic lower partial as well. And again, you can see there's no clasps like we had on the case before it with the Acres clasp and the Roach clasp. There's really no clasps at all. You know, all we need here is our two VKS attachments, and you can see the females. And then we have a laboratory prepared rest on the most distal tooth on each of the arches, and you can see the metal framework that's going to sit against those rests. But most of our retention is going to come from those two females, those two VKS attachments here. So again, even though it's the lower, as we rotate it forward, you can see we have a very aesthetic partial denture. There's no arms showing. There's really nothing there. All of the metal is on the lingual, and that's a partial denture I'd be happy to wear in my mouth if I had to wear a partial denture, because I certainly wouldn't want anybody seeing the clasps in my mouth. Here we are in the final appointment now that we've had a chance to try all that stuff in. And we're putting in the crowns on 11 and 12. Again, you get a good look at the VKS attachment coming off the mesial of that crown. And it's funny how patients really relate to it if you call it a trailer hitch. I know it's a VKS attachment, but there's something about that they get. And now the partial's going into place. We've engaged the cross arch roach ball attachment in between the crowns on 14 and 15 and pushing that partial into place to see how it fits and how it's going to do. Make sure the aesthetics are okay. Nothing is cemented at this point. Again, it's just still part of the try-in, having the patient bite together and making sure that things are where they need to be. We've now placed in the 3 lower crowns, the 2 bicuspids that are splinted together, and then the cuspid on the other side. And I'm pushing down on the partial to make sure it'll engage, and it will. And now as we cement the upper partial, notice that the crowns are in place in the attachment already. Okay, notice that we've got the splinted crowns on 11 and 12 in there already, because again, I want to make sure that as this partial and the crowns go to place here, that attachment is engaged. And the same thing on the lower. You'll notice the single crown on the lower left's in place, and the 2 splinted crowns on the other side are in place in the partial as I push it down. It's too critical as we cement these permanent restorations to take the chance that when we try the partials in, they're not going to fit. And so I always engage these and then push them down and hold them down and make sure they're down all the way. And as I hold these crowns down, they're already engaged with the partial. So I know when the cement sits like this that everything's in a position for the patient to be able to take it out and put it back in again and have these attachments engage. I can only clean. You can see we really can't get the cement out here under the saddle, but once the cement has had the chance to completely set, we'll take out the partial denture, we'll clean up all around, get all the excess cement from the lingual and the interproximal, knowing full well that when I push this back down, this partial is going to click into place because the attachments were engaged while the cement was setting on the upper and the lower. And that's a great feeling, knowing that every time I put that partial in, those attachments are going to engage, and that the patient's going to be able to do it alone at home. So again, this is a case where we were able to restore a lot of form and function at the same time, really have a significant aesthetic improvement as well. And as I look at these patients and see where they start off, a lot of these patients feel like they've had the same kind of smile makeover as one of our veneer patients. And in the meantime, they've gone from having, say, 4 teeth on the upper to 12 or 14 teeth on the upper. And it's really a neat feeling for them and for us alike.
Our goal in this clinical presentation has been to help you simplify combination casework, those cases where we have crowns, bridges, and partial dentures all in the same arch. I hope you've learned that the design team in our combination department can be a huge help to you, from the planning of the case to the actual preparations being done to the seating of the case. They can help ensure that all your combination cases are very successful. And I personally hope that you take a couple things away from this presentation as well. The first would be the need to take accurate pickup impressions, and this starts by temporarily cementing the restorations into place. And as a follow-up to that, you need to fight the urge to cement those restorations into place once you have them in your hand. Leave them in the pickup impression and send them back to the laboratory. This allows our technicians to make the framework in contact with the actual crowns and bridges on the models to increase the fit when you actually go back to the patient's mouth with these restorations. And the last point would be to take accurate bite registrations. Anywhere you've got an edentulous area, make sure you're using a wax bite rim. Don't just squirt bite registration material in there and send us what is commonly known as a mush bite. It can throw everything off from that very early step of the entire process. Thanks again for your time and attention today, and I want to thank you for your commitment to quality dentistry.